request Dr. Shilpa to present her talk on rocky situations, recognition of management of complications in SICS, including PC rent.
A very good morning. I would like to thank Dr. Kavita for giving me this opportunity here today and inviting me to this esteemed course. Today I'm going to talk on a few complications. We have been seeing quite a few videos here on and some very good cases. Complications can occur at any stage during the SICS. It could be at the time of the tunnel, during capsulotomy, at the plane of the iris, during nucleus removal, and also a PC rent. Now, this earlier on used to be a very dreaded complication that we all used to really be very worried about. But today, because of better technologies and better techniques, we are able to handle PC rents very well. I remember when I was doing my post-graduation, we used to call the vitreous Chacha Ji. So we used to say, Abhi Chacha Ji aa gaye. So this was something which none of us wanted to hear the word Chacha Ji in the OT. But now we have better techniques. So Chacha Ji is no longer so dreaded. Now coming to incision. Sorry. The placement, the length, and the depth of the incision is very, very important. If you have an anterior placement of the incision, you would have a wound leak or an astigmatism, and this definitely needs to be sutured. As far as posterior placement of the incision goes, you would have bleeding and also the chances of premature entry. The length of the incision, also very important, because if you have a shorter length, then there is more difficulty in delivering the nucleus, as well as endothelial and iris damage, as we have seen some videos here. A longer incision would definitely cause an improper apposition of the wound, causing leakage, and if you do happen to have something like this, do not feel don't get your ego in between and say, I will not suture. Go ahead and suture it, because that is very important. Wound leaks can cause endophthalmitis, and that is still more dreaded. Then the depth. If you have a superficial depth, then the chances of buttonholing are more. If you are deeper, then premature entry is a complication. Now you can see here, the depth has to be uniform throughout, and you should just see the blade. Now you saw there was a premature entry, then you need to go away from that area and make a new plane. And once you have made a new plane, go ahead with the rest of the surgery. And after that, because you have had a premature entry, always put some sutures there. Very, very important that put sutures. And you can cover those sutures with your conjunctival flap. The depth of the incision, very important that the depth has to be uniform throughout. It has to be, you should be able to see the blade, just about see the blade. If the blade is seen very clearly, that means you've had a premature entry. Now coming to capsulotomy, I thank Dr. Kavita for giving me some of these videos. This is a mature cataract. In SICS, we always tend to make larger capsulorhexis. As you can see here, it is tending to go towards the periphery. So it has been caught in time, and viscoelastic is put. Make a nick with a scissor, a Vanna scissor. Make sure that the anterior chamber is nice and deep, and then with your capsulorhexis forceps, from the other side, go ahead and complete the rhexis. So this is how you avoid an extension of the capsulorhexis, which again can cause PC rents and things like that. So this is something that you can completely avoid and make sure that your surgery goes off fine. Another possibility is, this is a hypermature cataract. The minute you make a nick, the liquid cortex is coming out. The visualization is difficult, so we put a viscoelastic to make sure that the visibility improves, but still you can see here the liquid cortex keeps coming up, and in such kind of Morganian cataracts, what happens is you don't have a proper base. So capsulorhexis as it is a little difficult. So you tend to make a smaller rhexis. So because of this small rhexis, you can have certain problems like delivery of the nucleus. In SICS, we always tend to make larger capsulorhexis so that the delivery of the nucleus and bringing it into the anterior chamber is much easier. Now you can see here, it is difficult to bring the nucleus up into the anterior chamber, and it takes a little bit of manipulation. Now hydro procedures also very important. Now you can see here that there is a fluid wave which has gone through, but it is not complete. So you try and go from the other side. Hydro dissection in SICS is very, very important, because without that you are not able to bring out the nucleus. And if you do not have, or you have an inadequate hydro dissection and you continue to go ahead, then you are likely to get the whole bag out. This is a very likely possibility. So even if it is taking a little more time, make sure that you do a very meticulous hydrodissection and a hydrodelineation. Now there are certain iris related problems that we face during SICS. Now this appears to be a very simple case. The nucleus also is quite soft. The irrigating vectors is being used to remove the nucleus. Up to now all fine, but then now you can see that there is an iris prolapse there, and this can be a problem. This is because of the deep incision. So every step in SICS is important. Every step you need to make sure that you do the right thing. Now this is another case where the iris prolapse was there, and during the nucleus removal there was an iridodialysis. Now this iridodialysis, you still go ahead, remove the nucleus, but you need to suture this dialysis, because otherwise that flap of the iris will come into the pupillary area and the patient will experience diplopia. Now this is one case where the pupil is a little small. The rhexis has been done, the OVD is put, and because the pupil is small, we cannot really visualize very well. We are going under the iris to be able to bring the nucleus up into the anterior chamber. It's a little difficult. You can see it's not very easy. And in the process of trying to go behind the iris and trying to bring that nucleus up, what has happened is this, you can see, is we are trying to push the viscoelastic under the nucleus and also trying to bring it out from the iris. Inferiorly there is iris there, and during this manipulation there is also hyphema because there is trauma to the iris while doing this procedure. Now the nucleus is out, and along with that you can see there that the bag also has come out completely. There is no posterior capsule, and this is another complication. Now in such cases you are not able to put PC IOL. You will have to think of some other option like an anterior chamber IOL. Of course we don't do it now, or iris fixated IOL. Now the posterior capsule, a rent in the posterior capsule can occur at any stage during your procedure of SICS. It could happen during a capsulotomy, hydrodissection, during the nucleus prolapse, during irrigation aspiration, or also during the insertion of the IOL. Now I have a video here. During irrigation aspiration with the Simcoe cannula, the cortex has been removed, and now while polishing the posterior capsule, now you can see that there is a rent there. You can see right in the center, there's a flap of the posterior capsule that you can see. Now, very important at this point, the first reflex when you see something like this happen is to come out. And that is something that you should never do. Remain inside, continue your irrigation, put in viscoelastic from your main incision or the side port, and after that, then you come out with your irrigation. And before you do a vitrectomy, even after you have put an IOL, and now in this case there wasn't much of vitreous, but you could do a vitrectomy first and then put an IOL, or if there isn't much vitreous, you can put the lens first, suture the incision, because having a closed chamber in such cases before you do the vitrectomy is important. If you have a big incision which is it can cause more of vitreous to come out, and that's why suture the incision first and then go ahead with the vitrectomy. Thank you very much. Any questions?
Thank you, Dr. Shilpa. Now the floor is open for any discussion. If any delegate wants to ask any question, please use the mic in the aisle. Yes, sir. Please go ahead.
Madam, why did you stop using ACI oils?
Sorry?
You said you stopped implanting ACI oils, anterior chamber IOLs. Why did you stop using it?
Well, and AC IOLs, I feel the lens is not in the proper position. Now, in the natural course, it is always better to put a lens behind the iris. And nowadays, with the iris fixated IOLs, it's very safe. Anterior chamber IOLs, we have seen, have caused a lot of problems like secondary glaucomas, being closer to the cornea, corneal decompensations. We have seen a lot of these.
So can I just elaborate on that? You shouldn't use any implant as an emergency basis. You know, ye nahi to wo kar do, wo nahi to ye kar do. If you're planning for a ACL, you should be prepared for it. You should measure the white to white. You should see how much is the angle, and have you done the gonioscopy pre-operatively, whether there's any space, whether you have a fitment for it. You know, because if you see Dr. Manoranjan Das, we keep ACLs, he removes it. You know, so we have to plan for it. If it's a planned, it's very good, because most of these eventualities will be unplanned. That's the reason why on table it's better always to avoid. You leave the patient aphakic, reconsider, and then take up for the next procedure.
Just to add on that, AC, I will tell this thing. Usually, most of the time, I personally, as a surgeon, feel that it is unnecessarily blamed ACIL. But the thing is that you are not managing your case; you are managing some other case which is badly done. So only if you get a piece of rent and you don't have any other lens which has got the same power of ACIL, and you don't have any choices of paying patient, I feel a proper vitrectomy, and if you can achieve a round pupil and proper white to white diameter, what you achieve, and then you 0.5 XL more than this thing, what you keep it, it will be done. But if we aim at a round pupil, when you people have got irregular pupil with synechia, then iris is floppy, all those stages, that's not a point to put any ACIOs.
We also see patients with ACIOLs coming to you time and again complaining of pain. Every time that the iris rubs against the IOL, there's pain. So this is another thing which, in fact, that is one of the deterrents for me to put an ACIOL. Even an iris fixated lens, you can, like doctor said here, that we can leave the patient aphakic, wait for some time, and as a secondary procedure, you do the whichever secondary IOL that
we have the luxury of having Dr. Samar Basak in our midst. May I have the liberty of asking him his opinion on placement of ACIOL?
So what you have been told that rightly, Manoranjan Das also told that ACIL, that we see a lot of corneal decompensation and pseudophakic bullous keratopathy. But when we manage these cases, in some of the cases we keep the ACIL. Probably those are stable IOLs. We take the history when the surgery was done. If it is like 15 years back, ACIL stable, we see the movement of the iris, movement of the IOL. Then we do not take the, and these patients are actually old-aged patients. The other multiple procedure, we just keep the ACIL and do the either dissect or demec procedure. But when we see in recently done ACIL cases, then we see a lot of instability. And we also see the distance between corneal endothelium to ACIL by the anterior chamber depth. If it is more than 2.5 millimeter, then we consider of putting a demec or dissect graft. But if it is less, then we remove it, do a scleral fixation or posterior iris fixation with standard of care of vitrectomy and all this.
Thank you, sir.